Thank you. So, my dream and I love to do 3D vitreous surgery because it's a fantasy come true. Next is, I think the next step will be to do robotic retina surgery, which is my friend Dr. Fanny in Norway in Belgium is doing. And one day it will become a tele robotic surgery. So this is what I'm using. There's no financial interest. This Zeiss claims as the first digital microscope, the new era of visualization of ophthalmic surgery delivered by the first digital microscope. They have the digital optics, which you listen to the whole day, the ad vision and the cloud connectivity. And without compromises, visualization in digital and hybrid mode automatically adjusts to your surgical steps and auto adjust to your surgical workflow and surgical steps. So this is a 3D high definition camera mounted on the microscope and a computer which processes the input and output signals. So once you have the computer, you reduce the light, you can change the color contrast, and a high definition display unit is there. So you need a 3D glasses, which you all used it today. And advantages they experience in post segment best combined with the chandelier illumination. You can reduce the illumination, and it's like, as I said, you're sitting on the surface of the retina and then operating. Gradual transition from binoculars to screen, excellent stereoscopic perception, large screen, high resolution is helpful in crisp viewing, lesser lag in transmission, and best for practical education to resident fellows, nurses, and all the one present in the OT. This one is, according to me, the surgeon's neck remains relaxed is not true, because you, instead of looking into the microscope, you are looking at the side. My suggestion is you should do exercise, particularly dance, so that you have make sure the antagonist and protagonist muscle of the neck and the back is strong. But that's dance is the only good exercise. And apart from that, gym is obviously important, and clear distinction of membranes while dissecting. I always feel that like there's a two layers can be seen in the 3D, which is in the microscope you'll see only a small part of the membrane, and better visualization of stained vitreous. So it allows to overcome some of the challenges associated with VR surgery. Screen delivers excellent depth perception and more minute anatomical details, which will help improve understanding and knowledge retention. I met some of my friends in US who are excellent VR surgeon, but they said they don't want 3D because in case they make a complication, the entire OT will come to know. That's true, because you see all the minute thing right from the center to the extreme periphery of the screen. And the entire team can see on the monitor exactly what the surgeon is doing or seeing during this surgery. So this is a OT setup where we have everybody has a 3D glass, and then we also have a glass door in the OT. If somebody doesn't want to change, they can see from the outside, and you can now transmit 3D vitreous surgery also. I recently did 2 vitreous surgery, a 3D live transmission, one to Egypt and the other to in some part of the South America. So I think this is what the technology is making, and I think you can do, and whatever you are seeing, everybody else can see. And this is again I'll show you some cases. This is a 19-year-old male presented to us on 7th February with a complaining blurring in superior half of vision. He had fell down while playing cricket at the college sports day. And this is we planned, it was an old partial rhegmatogenous retinal detachment, and the patient did not recognize it was because of the long-standing detachment, because the macula was not involved for long. And this is the pre-op fundus photograph. You see a 6/9 N6 vision, but when the macula was involved and the fovea was not involved, with 6/9 N6, he saw half of the vision is not there, and you can see the retinal break in the periphery here. This is the retinal break, which is the cause for detachment. And then this is a pre-operative OCT macula, and as this is again a 2D you are going to see, but I love doing scleral buckling surgery. The reason is that still scleral buckling surgery in an eye like this, you can have a 6/9 N6 maintained and also produce mild myopia because you don't have to tighten like before. And earlier days they described a thing called 8R, because it's like a dumbbell shaped, they tighten the buckle, which is not required. Aruga started it, and then later Charles Keepens modified by doing implant, and now we all do explant, and we know moderate tightening is enough to make sure that you create an artificial ora serrata. So you have to clear the stenons, and you can see I have just marked uh, where the retinal break is there, and I use the 4-0 ethibond for the buckle, where doing the bob technique you can place it. And I have also earlier done scleral dissection and put the scleral buckle, but that's a little risky because you have to dissect the sclera along where there's a risk of perforation. And here you only one suture, and you make sure that the knot is on the center of the buckle, so that now I'm passing the 240 band through the behind the muscle and the sutures, and then make the scleral flap, which I make it so that it's like a belt loop. So that's why it's called a belt buckle, or in a scleral buckle for 360 degree. So I actually choose between the muscle ring, which represents the ora serrata, and then the vortex, which is the equator. So it's put in between to create an artificial ora serrata to prevent peripheral traction, which can produce breaks in the future. So most of the time, I think more than 95% of the time, with one surgery, the patient can get 6, 6 and 5. And there's a big comparison done between scleral buckling and vitrectomy. Primary vitrectomy has the risk of cataract increasing, but in this, the cataract increase is almost nil. And we had in American Academy, they asked me, what will you do? You have a choice of doing pneumoretinopexy, scleral buckling, and a primary vitrectomy. And I choose scleral buckling even for an actress. The reason is, I know I dissect the conjunctiva and the tenons properly, and this is a drainage which I do, where I make a scleral flap, and then because I learned from trabeculectomy, because once upon a time I was doing scleral implant, Dr. Charles Keepan's technique described by Dr. Badrinath to me, and he was insisting I should do implant. Almost till 1988 I did implant, and then switched over to explant when I went to Bombay. And he used to scold me that why are you switched over to explant, because you should do implant. But then I told him, this is just to make a single air bubble, where I do the single bubble thing. So here, in case you have a suspicion of any complication, it's under the buckle. We do a cryo and also check internally, and you can see the knot comes on the center of the buckle, which is well covered by the conjunctiva, so that even the scleral sutures are not exposed. And I do a paracentesis in case you have to make the intraocular pressure normal, and also the buckle height less, and finally have an internal support, which is a non-expanding gas bubble or even air you can use. As I said, the knot is exactly on the center of the buckle, so that it doesn't erode over the sclera or over the conjunctiva, and then the tenons is covers well, which I use the only one suture for the buckle. Rest will not have any sutures, and I use the Reli seal I use. Sometime earlier we were using the imported one, which is expensive. So where you can use the glue for closing the conjunctiva, so that the patient does not have to come for suture removal, or there's no irritation in the post-operative period. Only thing is you have to make sure that you put the glue properly, so that the conjunctiva is closed well. For that, you should not have a conjunctival tear, which can happen. So this is the pictures taken during intraop while doing the 3D, and then this is a post-op. You can see small pocket of fluid which will get absorbed, and this is a post-op with a 612 vision in the immediate post-op with the refraction, because slight myopia will be there. And this is a live surgery which I did. I have edited, which is there which I did it in. The conference was in Acapulco, in Mexico, and surgery was done in a hospital in the Mexico City. So I flew down from the conference, operated, and same evening went back and did the. This is on the 3D. Okay, 3D is over. So anyhow, this is a 3D transmission from Mexico City to Acapulco. The retinal, you can see a complicated traction retinal detachment, and I love to take up most complicated patients and do live surgery, and I did it in, I think, 40 minutes. So they were all astonished, and they asked me, how do you have this energy after come there and dance till 3 in the morning? And everybody was with tequila and dancing, and I don't drink, so that's another thing. So here I do a bimanual surgery. You can see I have the chandelier illumination, and then use the forceps in one hand and dissecting the membrane using the curved scissors and removing all the traction which is being produced. So finally I did the entire surgery without any iatrogenic break. And I remember in 95 when Dr. D. Juan and Dr. Brooks McQueen from Durham, um, where Dr. McMur was there, came and they said an 18% iatrogenic breaks are allowed in vitreoretinal surgery, and Dr. Jonovich got very angry and said, how can you have 18% of iatrogenic break? That was in 95, and now I think we aim at almost 100% not to have an iatrogenic break when a complex detachments like this. You may have bleeding like this, so you have to know to control it, control your and then you can see the membranes will be totally dissected, and the patient got I think excellent vision. I am in touch with them, so I am actually I am more popular in South America than in India, I think. And I think because they have the worst diabetic retinopathy patients in the world, because they are also having fat food, they have the wrong food from America, and also a special Coca-Cola which has more sugar than even the Coca-Cola in America. So they call it I forgot, Mexico Coke or something, and even these guys come to Mexico, they come to America and have this. So finally you have a fluid air exchange at the conclusion, and so the teaching is excellent. And then you can do bimanual vitreous surgery, and with the chandelier, which is you can see this is done, and then I did a pan-retinal photocoagulation. So the whole thing is to have because most of the things are under your control, the laser, the visualization, focusing, except putting the, even that you can do it with the channel illumination, putting the biome and removing the biome. And so here you see finally the with the fluid air exchange and pan-retinal photocoagulation, the retina is totally attached with no, and finally the ports are removed. And this is a Cairo retinal surgery, another complicated which were transmitted from my OT to Cairo, and then I flew down to Cairo to give the talk the same evening. And this is again a traction retinal detachment, preoperative, showing hand motion vision, and you can see the OCT shows a detached macula, disorganized retinal layers, and thickened and taut posterior hyaloid phase with a full thickness macular hole. So which you could have been missed in the without the OCT. And this is the B scan which shows, and that's the so this is a 3-port, and I use this is a stiletto which was made by Dork, and I now use 2 ports, and actually just broke after almost 15 years. This is designed by Dr. Klaus Eckhart, and now I, instead of having the twin port, I have 2 ports and keep 2 illumination where we can put it, and then do the bimanual surgery. So this is staining the vitreous with the steroid, and then clearing the anteroposterior and tangential traction, and you can see that all the vitreous uncut vitreous have been removed. So again you have to learn to know what's the complication which can happen and then prevent it. You cannot say the complication will happen, and I think I don't know how to describe that. I have developed a tactile sensation through the forceps, so I know the touch and feel as though you are touching the membrane with your own hand and doing it like the regular general surgeons who are doing, and now come back to the laparoscopic surgery, which is not the touch and feel, but it's through the instruments, and that's what we have to develop, and that's given in some form as the mirror neurons which happen in the brain. So we have the plasticity of the brain which should use it. So there's no age bar for learning anything new, and here you see there's it's a combined traction retinal detachment. We can also removing the stained vitreous which is attached to the and you are using forceps and the cutter to separate the vitreous from the detached retina, and then you're also clearing the pre-retinal hemorrhage. So in this eye, actually, because of the it's a regmotogenous retinal detachment with combined detachment, I did fluid air exchange, completed the pan-retinal photocoagulation, retinal photocoagulation around the break, and finally did air silicone oil exchange, and also injected this is the break which was there in the periphery, where you dithermess so that you can identify under the air, and there was some amount of preretinal hemorrhage, and this patient was not operated, getting operated in Sion Hospital because the instrument was not working. So I have joined as a emeritus professor of ophthalmology to help the poor patients there. So I have decided to do all these complicated surgeries free, so that because I earned enough to do well. So this is the patient which I demonstrated for a Cairo, and this is a post-op picture where you can see the attached retina with some amount of hemorrhages here and there. So I do a serial photograph, and this is the final checkup, and then so summary, I think the vitreoretinal surgery remains challenging but is advanced due to improved surgical instrumentation and 3D vitrectomy technique, careful preoperative and operative planning, including the choice of instruments, gauge, tamponade is the key for successful surgery, often enabling meaningful visual rehabilitation even in the severe cases like this. This case was given up, and I actually taken an informed consent of neovascular glaucoma producing blind full pain eye, but fortunately with the anti-VEGF laser and also removing all the membranes, I think touch wood not seen any neovascular glaucoma. Anyway, Dr. Badrinath always taught me 99% hard work, he said. I said 99% work with passion and 1% inspiration. There's no luck. There's no bad luck and there's no good luck. And I think whatever Gaurav was talking, I think he mentioned somehow it happened. I think it all happened because of the skill which is there in the hand, which is developed. And so I think I thank my colleagues, Dr. Jaydeep. Afroz is an optometrist. Now I'm training her to edit all my videos. And then the Samir is my IT head, and Rohan is a fellow from Jaipur. So thank you. And even if your fantasy comes true, that doesn't mean you should stop dreaming. So next step is to do robotic surgery. Thank you. Any questions or comments?
Sir, do you routinely use two-port chandelier system for all your diabetic TRDs, or?
No, as I said, I have a game plan. I decide the day before what I want. But anyway, in OT, everything should be ready. That's why I tell them I will keep changing my plan on the table. So when I ask if I plan a chandelier and I don't do it, I tell the sister, don't question me. So I think the idea is to have a game plan. It's a logarithm which Steve Charles has given in his book, but it doesn't work like that.
Yeah.
So you have to have the logarithm and use it like a computer on the table, your the spinal level, it will work.
And for the first patients that you showed, you didn't buckle, you made a scleral flap for drainage. So
Yeah,
do you routinely
I always do
a
scleral flap.
or you just do a drainage point through a needle, or?
No, because needle people have reported hemorrhage. Even I have tried, and it's a blind procedure. Even though you can do using the
after making a scleral cut down, you do it with
Correct.
a needle?
Because I learned when I was doing the scleral implant, I found it was easy to make a drainage thing and then do the drainage. Then I learned from the trabeculectomy people that when I used to do trabeculectomy when I was a postgraduate, not as a consultant. So I thought, why not I use that? The idea is you can protect the scleral flap, will protect the perforation site, and also you don't have to do a full thickness scleral, which may not close at all.
Right.
So that I have to publish. Somehow I'm lazy. I should tell my fellows to publish it. I'm doing it for 32 years now.
Hello, sir. Sir, for long-standing retinal tractional detachments, like for more than 1 year or 2 years, we are ensured that there are no iatrogenic breaks. But do you still make a retinotomy and drain the fluid, because that long-standing fluid will take very long time to go on its own?
Yeah. So what I do is, if I clear all the traction, and then I use a PFCL to separate, put the fluid away from the macula, and use the silicone oil as a tamponade. But 100% there should not be break, because if there's a break, it will not work. So if there's no break, and I think if no iatrogenic break has happened, then I don't make a retinotomy. But if there's a break happen, I use that for endodrainage and make sure I do a good laser and pan-retinal photocoagulation and complete the surgery.
Okay, So for the first case that you did buckling, can we get away with only pneumatic retinopexy? That
You
is very
can,
common.
but somehow I don't know why. I have done a lot of pneumatic retinopexy, and Dr. Jonovich has probably put in my mind that's the weekend surgery. He says surgeons are lazy on Friday; they don't want to do surgery because their Saturday, Sunday is holiday, so they do pneumoretinopexy, and Monday, if there's a recurrence, they will do a buckle. So I feel why not do if you do according to me, scleral buckling is a fine art surgery, not the technique. The idea is in the mind where you locate the break, do the less cryo, and then moderate buckle, it will be permanent. And pneumoretinopexy, I think 90% it works, and same thing with scleral buckling, you can say 95% it works. Nothing is 100%, but I somehow the problem is you make sure you want the patient to follow the position, which is a 5-day punishment for the patient. Here, I learned this drainage. That's why I don't know whether you are all not probably born as a surgeon also. Dr. Badrinath, Dr. Nakpal, Dr. Nam, they had a war during the surgery between drainage and non-drainage, and between implant and explant. Any of those days are gone. And I remember fighting with Dr. Nakpal in '86. He says, no, you people why are you draining? It's a complicated thing, you'll tell. I said, we reattach the retina on the table, so no need for positioning the patient. Still, I use a non-expandable gas just for volume, and so that you don't have to tighten the buckle, because under the air, scleral rigidity will change. So moderate buckle is good. So I wanted to do a mathematical calculation, which I'm not sure how to tighten, because I think Dr. Nakpal's technique was to tighten the buckle so much. Even Linkoff was doing that. I think you have to learn from everybody, finally see what is good for the patient. I think everybody we have to aim at making the patient from PL to even 2/60. He can see his plate on his table and go to toilet on his own. And I think that's why I'm happy and I'm growing young. That's one secret. Because from '84, whichever patients have been given up, even by Dr. Badrinath, I used to take and operate. I have failed many times. Even now I fail, because I give only 1% chance, and 99% chance fail. So recently a Muslim patient was asking me that what is the guarantee. He came with the same TRD, and I told him at 20% I'm explaining to you, and you're asking me guarantee. I said, please go to a dargah or a mosque and get operated. I told him. He didn't come back. I know he's angry with me, but I said, how will you get to how can I get guarantee? And he 1 year he's having this TRD, and he's asking for guarantee. And it's again I want to tell his topic also, complicated surgery made easy. I have an objection, because you should not make anything easy to even even to the doctors and the patient, because we should tell so much of training has been gone in doing a cataract surgery. Why should we tell even I think Gaurav mentioned 5 to 10 minutes we do a surgery. Don't talk about time here. You tell so much of expertise is required to do a cataract is the most difficult job. Why I'm saying the 99.99 who are happy don't know the problem, and 0.01 who comes to us with the cystoid macular edema, retinal detachment, or endophthalmitis, 1 in 1,000, they come and eat my head. So I tell them, what did the doctor? No, doctor told me no problem. I said, why should you tell no problem? No, you tell there's a problem and get the 6/4 also, and the patient will benefit. But 99% of the cataract patients do not know they have complication, which is surprising, because people think it's like 100% successful. No, 99.99 is so that's why I asked the patient, will you select the airport which has 99.99% successful landing or 100% landing? No. So there we have IATA rules which prevents accidents, and in surgery we make it simple and may have problem. So that's why Dr. Rashmi, whose name we have the video award, he always told me, Natrajan, this cataract surgery is lifetime surgery for the patient. You please spend, he'll tell my cataract surgeon, spend time so that even for YAG laser you shouldn't come. He says, if you do the surgery well and clean the posterior capsule, why should you have don't take it as 50% will have after cataract. You do well, maybe 80% will not have after cataract. So I think every step is important, and which is we our eye surgeons within ourselves should tell is important to have the best vision. Quality. No? TQM is there in factories, why not in surgery? Total quality management. Thank you.
Thank you, sir.